There's a number hiding on every blood pressure reading you have ever received. A number your doctor mentions at almost every single visit. You have seen it written down dozens, maybe hundreds of times. Two figures, one sitting on top of the other. And yet, despite all those readings, despite all those conversations, the most important thing about those two numbers has probably never been explained to you properly. Because here is the truth that most people over 60 have never been told clearly. One of those numbers is dramatically more dangerous than the other, and the one doing the most damage may not be the one you've been worrying about. My name is Dr. Wilson. I spent 22 years as a cardiovascular specialist, and in that time I've seen what uncontrolled blood pressure does to a human body up close. I have reviewed the scans, studied the damage, and had the conversations that nobody wants to have. Conversations with families trying to understand why their loved one collapsed, why their speech disappeared overnight, why someone who seemed perfectly fine last week is now fighting for function. I have watched intelligent, health-conscious people suffer catastrophic events because they were paying attention to the wrong number. And I am not going to let that happen to you. What I am about to walk you through is grounded in decades of large-scale clinical research. We're talking about studies that tracked hundreds of thousands of people over many years, looking at who had heart attacks, who suffered strokes, who developed kidney failure, and who died too early. The pattern that emerged from all of that data is consistent and clear. And once you understand it, you will never look at a blood pressure reading the same way again. Let's start from the very beginning, because I want you to genuinely understand what is happening inside your body when that cuff tightens around your arm. Your heart does not push blood out in a steady, continuous stream. It beats and pulses. It contracts, sends a surge of blood rushing outward into your arteries, then relaxes and refills before doing it all over again. That rhythmic pumping is what creates two distinct pressure values with every single cycle. The number on top, the systolic reading, captures the peak pressure that builds inside your arteries at the exact moment your heart squeezes. It is the surge, the force, the crest of that wave. The number on the bottom, the diastolic reading, reflects the pressure that remains in your arteries during the resting moment between beats when your heart is filling back up. It is the baseline, the quiet interval between surges. So if your reading comes out as 155/88, that means your peak pressure reaches 155 and between beats it settles at 88. For many years, both numbers were treated with roughly equal concern. Elevated diastolic pressure was considered just as alarming as elevated systolic. Textbooks, medical training, and public health messaging all emphasize the danger of both figures rising together. And for younger adults, that concern is entirely appropriate. But as the research base grew, as scientists followed larger populations over longer periods, something important became visible. A shift, a pattern that was particularly strong in one specific group. People over the age of 60. Two patients I evaluated years apart stay in my memory because they represent this pattern perfectly. The first was a woman named Frances, 71 years old, who came in for a cardiovascular review. Her reading that afternoon was 168/72. Frances was relaxed about it. She told me that her bottom number had always been her benchmark, and since 72 was solidly in the normal range, she felt she was doing well. Her previous physician had apparently reinforced this, noting that her diastolic was fine and that the top number was just something that tended to drift upward as you got older. She had been living with a systolic reading in the 160s for nearly 3 years. 8 months after that appointment, Frances had a stroke. The right side of her face drooped. Her left arm became difficult to control. The vibrant woman who had been managing her own household and caring for her grandchildren now needed assistance with basic daily tasks. The culprit was years of elevated systolic pressure steadily damaging the blood vessels feeding her brain, while attention was directed elsewhere. The second patient was a 66-year-old man named Gerald. His reading was 130/97. Gerald was genuinely frightened. He had read several articles suggesting that the diastolic number was the one that reflected constant strain on the heart, that a persistently elevated diastolic meant the heart was never getting a proper rest. He was convinced he was heading for a cardiac event. I ran a thorough workup on Gerald, stress testing, echocardiography, arterial imaging. His heart was functioning well. His coronary vessels showed minimal disease. His diastolic elevation was worth addressing, but his actual cardiovascular risk was far more manageable than his anxiety suggested. He needed monitoring and lifestyle adjustments, not emergency intervention. Same diagnostic category, completely different clinical reality. And the difference came down entirely to which number was driving the problem. So here's the answer you came here for. After age 60, your systolic blood pressure, that top number, is the far more powerful predictor of heart attack, stroke, kidney damage, and cardiovascular death. Multiple large-scale studies, including the Framingham Heart Study, tracking thousands of participants across decades, and research programs following over 300,000 individuals, all reached the same conclusion. In older adults, systolic pressure is 2 to 3 times more predictive of serious cardiovascular outcomes than diastolic pressure. And there's a specific condition at the center of this. It is called isolated systolic hypertension, and it is exactly what Francis had. This is when the top number climbs significantly while the bottom number remains normal or even drops. For a long time, some physicians viewed this as a relatively benign feature of aging, the body just changing over time, not necessarily a dangerous pathology. That interpretation turned out to be deeply wrong. Isolated systolic hypertension is a serious condition that sharply raises the risk of stroke, heart failure, heart attack, and kidney disease. Clinical trials demonstrated that treating it reduces stroke risk by 30 to 40% and lowers heart attack risk by 15 to 25%. Those numbers translate to an enormous number of lives and disabilities prevented every single year. To understand why this happens, you need to understand what aging does to your arteries. When you are young, your arterial walls contain elastic fibers that behave almost like a soft rubber tube. When your heart pumps, those walls flex outward slightly, absorbing some of the pressure surge, smoothing out the force before it reaches your organs. Then during the resting interval, the walls recoil inward, helping to maintain pressure in the system. This elasticity keeps your systolic reading relatively contained and your diastolic reading stable. As you age, that elasticity progressively deteriorates. The flexible fibers break down. Stiffer structural proteins take their place. Calcium accumulates in the vessel walls. Fatty deposits build up along the inner lining. Your arteries transition from something resembling flexible tubing into something closer to a rigid pipe. Now, when your heart contracts, there is nothing to absorb the pressure surge. It transmits directly through the system, and the systolic reading climbs. But during the rest phase, those stiff walls no longer recoil the way they once did, so the diastolic reading may stay flat or even fall. The gap between the two numbers widens. And that widening gap, what cardiologists call pulse pressure, is itself a meaningful indicator of arterial stiffness and cardiovascular risk. But here is what matters most. That elevated systolic pressure is not simply a passive reflection of stiff arteries. It is actively causing damage with every single heartbeat. Every pressure surge is a mechanical force being transmitted through vessels that were not designed to absorb it. The small, delicate blood vessels inside your brain, your kidneys, your eyes, and your heart are absorbing wave after wave of excessive force. Thousands of times a day after day, year after year. Think of it in physical terms. A single strong wave against a concrete wall causes no visible damage. But sustained wave action over years will fracture and erode even the strongest barrier. That is what chronically elevated systolic pressure does to your vasculature. It creates microscopic injuries in the vessel walls. The body's repair processes respond to those injuries, but those same repair processes contribute to inflammation, scarring, and further stiffening. The cycle reinforces itself. The brain is particularly exposed. Small vessels deep in brain tissue develop structural weaknesses from the repetitive pressure trauma. Some of these rupture, causing hemorrhagic events. Others gradually narrow and close, causing tissue loss from reduced blood flow. And even in the absence of a clinically obvious stroke, this process continues silently. Tiny areas of brain tissue are lost over time. Cognitive sharpness declines. Memory falters. Reaction time slows. What is often labeled as age-related cognitive decline or attributed to other causes is, in a significant number of cases, the accumulated neurological toll of years of uncontrolled systolic pressure. The heart pays a price too. When the heart has to push blood into a high-resistance, stiff arterial system with every beat, it has to work harder than it was built to sustain. Over years, the muscular wall of the heart's main pumping chamber thickens in response to that chronic overload. A thickened heart wall is a stiffer heart wall. It does not relax and fill efficiently between beats. It becomes prone to arrhythmia. It sets the stage for heart failure. Not the kind that comes on suddenly after a blocked artery, but the slow, progressive kind that develops over years of mechanical overwork. The kidneys contain millions of microscopic filtration units, each one dependent on a tiny network of delicate capillaries. Elevated systolic pressure damages those capillaries over time. Filtration efficiency drops. The kidneys begin to lose their ability to regulate fluid balance and blood pressure, which then makes the hypertension harder to control, which causes more kidney damage. This cycle, once established, can progress over years to the point where dialysis becomes necessary. Now, there's an important nuance to address, because the relationship between systolic and diastolic is not simply that one matters and the other does not. A very low diastolic reading in someone with extremely stiff arteries is its own warning sign. During the rest phase of each heartbeat, the coronary arteries, the vessels that supply the heart muscle itself, do most of their filling. If the diastolic pressure drops too low, the heart muscle may not receive adequate blood flow during that resting interval, even if the coronary arteries themselves are open and unblocked. This can cause chest discomfort and cardiac stress. So the goal is never simply to push diastolic as low as possible. The goal is balanced, well-controlled pressure across both readings, with particular emphasis on bringing systolic down to a safe range. According to current guidance from major cardiovascular organizations, hypertension is now defined as a reading of 130/80 or higher. For adults over 65, the primary clinical target is getting systolic pressure below 130. For those who are younger, healthier, and able to tolerate more aggressive treatment, targets as low as 120 may offer additional benefit, based on trial data showing meaningful reductions in serious cardiovascular events with intensive pressure control. For older adults who are frail, managing multiple complex conditions, or at risk of falls and medication complications, slightly more conservative targets are sometimes appropriate. But the principle of treating elevated systolic pressure does not change. It remains the priority. With readings above 140, medication. Neither alone is usually sufficient. Both together bringing systolic pressure down requires both behavioral change and, for most people over 60, give you the best chance at meaningful, lasting control. On the lifestyle side, sodium reduction is one of the most powerful tools available. The typical modern diet delivers far more sodium than the body needs, and excess sodium causes the body to retain fluid, increasing the volume of blood moving through the vascular system, which raises pressure. Cutting back to 1,500 to 2,000 milligrams daily, and that means reading labels, reducing processed foods, and not adding salt during cooking or at the table, can lower systolic pressure by 5 to 10 points on its own. That is a clinically significant reduction. Weight reduction in those who are carrying excess body mass also contributes meaningfully. Aerobic physical activity, walking, swimming, cycling, anything sustained and moderate, improves the elasticity of arterial walls over time, not just cardiovascular fitness. The exercise itself is a direct intervention on arterial health. Alcohol in quantities above 1 drink per day for women and 2 for men tends to push blood pressure upward. Chronic stress activates hormonal systems that sustain elevated pressure over time. So regular relaxation practices, whether that is meditative breathing, gentle movement, time in nature, or whatever genuinely helps your nervous system settle. These are not peripheral concerns. They are part of the treatment plan. For most people over 60 with systolic readings persistently above 140, however, these changes need to be paired with medication. This is not a concession or a sign that you have failed at managing your health. Arterial stiffening is a structural process. No amount of healthy eating reverses the physical changes that age brings to vascular tissue. Medication addresses the pressure directly, protecting your organs, while lifestyle changes support the process. There are several classes of medications used to treat systolic hypertension, and many people ultimately require 2 or 3 working together to achieve adequate control. This is expected and appropriate. Different combinations suit different people depending on other health conditions, kidney function, and individual response. The important thing is not to abandon a medication regimen because the first option causes a side effect, but to communicate with your physician and find the right combination that you can take consistently. Home monitoring matters enormously in this process. A quality, validated upper arm blood pressure device, used at consistent times, typically morning before medication and evening, gives you and your physician a far clearer picture of your actual pressure patterns than any single in-office reading. Blood pressure fluctuates throughout the day, and some people have readings that are artificially elevated in clinical settings due to anxiety, while others have normal in-office readings that mask elevations they experience at home and during sleep. Your home data removes that ambiguity. And consistency of treatment, taking medications at the same time each day without skipping, matters more than people often realize. Gaps in medication allow pressure to rebound, sometimes sharply. The swings that result from inconsistent treatment can in some ways be more damaging than a stable elevation. Routine, habit, and structure are your allies here. Never adjust or discontinue a blood pressure medication without speaking to your physician first. Sudden discontinuation of some medications causes a rebound surge in pressure that can be dangerous. If you are experiencing side effects or have concerns about cost or convenience, those are conversations worth having with your doctor. There are solutions, but the decision to change course needs to happen through that conversation, not independently. Frances, the patient I mentioned at the beginning, stayed in my thoughts long after her stroke. Not because her case was unusual, but because it was preventable. The information existed. The treatments existed. The measurement that would have told her she was in danger was taken at every appointment. What was missing was a clear, direct explanation of what that top number meant, what it was doing to her brain with every beat of her heart, and why it mattered more than the bottom number that everyone kept telling her looked fine. She had been given data without context, numbers without meaning. And in that gap between data and understanding, years of damage accumulated quietly. You now have that context. You understand that in adults over 60, systolic blood pressure carries the greater burden of cardiovascular risk. You understand the physiological reason. That arterial stiffening shifts the danger profile fundamentally, amplifying systolic surges while the diastolic baseline may appear reassuringly normal. You understand that isolated systolic hypertension is not a benign quirk of aging, but a treatable condition with real consequences when left unaddressed. You understand the mechanisms through which elevated systolic pressure injures the brain, the heart, and the kidneys over time. And you understand what can be done about it. Concretely, practically, starting with your next blood pressure check. Check your reading this week. Write it down. Look at that top number with fresh eyes. If it is sitting above 130, have an honest conversation with your physician about what is being done to address it. Not just your diastolic, not just a general sense that it is a little high, but a specific plan for bringing your systolic to a safe level and keeping it there. If you're already on medication, take it every day. Monitor at home. Track your progress. Stay engaged with your own numbers. Your vascular system has been sustaining your life for over 6 decades. Every one of those beats has been faithfully delivering oxygen and nutrients to the tissues that keep you thinking, moving, and living fully. It has done its part without any conscious effort on yours. What it needs from you now is informed attention, specifically attention to that top number, the one that rises with age, the one that pounds quietly against your arterial walls, the one that the research is unambiguous about. That is the number that tells the true story of your cardiovascular risk after 60. And now you know how to read it.